Hi everyone. Today's PowerPoint we will be discussing hypertension, and I am Professor Erica Martins. Okay, to start, we're going to cover our learning objectives. So at the end of this PowerPoint, these objectives are something that you should go through and be able to answer. So identifying the stages of hypertension, defining risk factors related to hypertension, discussing the management of a patient diagnosed with hypertension, explain how blood pressure is regulated, and lastly, identify treatment recommendations published by the 8th Joint National Committee, also known as JNC 8. So hypertension, also known as high blood pressure, is one of the most important modifiable risk factors that can lead to the development of cardiovascular disease. As blood pressure increases, so does the risk of myocardial infarction, also known as an MI or a heart attack, heart failure, stroke, and renal disease. Heart disease often directly related to hypertension accounts for 23.7% of all deaths each year in the United States. Healthy People 2020 lists the number of adults with hypertension whose blood pressure is under control as one of the 26 high priority leading health indicators for the coming decade. The National Health and Nutrition Examination Survey, also known as NHANES, tracks prevention, treatment, and control of hypertension. Data from NHANES shows that 83% of people 20 years of age and older with hypertension were aware that they had high blood pressure. Of these, 76 people were being treated. Of those aware of their hypertension, 48% did not currently have their blood pressure well controlled. The American College of Cardiology Foundation and the American Heart Association provides performance measures for hypertension management that address not only treatment, but also control of blood pressure to target goals. Target goals have been updated with new information from the evidence-based guidelines for the management of high blood pressure in adults report from the 8th Joint National Committee. Target goals take into consideration both age and comorbidities when recommending treatment options. National guidelines are designed to apply to all racial and ethnic groups. However, certain groups have a higher incidence of risk factors. I do want to talk a little bit about racial and ethnic groups. So please look at page 679 in your book, Promoting Health Equity. So this has a lot of good information on it, and it's important to be aware that there are some ethnic groups that are at higher risk of developing hypertension, and then there are other ethnic groups that with the research are less likely to reach out for assistance and treatment to actually treat their hypertension. So again, please look in your book at page 679, Promoting Health Equity, as this will go into further detail about that. So factors influencing blood pressure. So we'll first talk about blood pressure, which is the force exerted by the blood against the walls of the blood vessel. Its primary function is primarily a function of cardiac output and systemic vascular resistance. Cardiac output is the total blood flow through the systemic or pulmonary circulation per minute. It is described as the stroke volume, which is the amount of blood pumped out of the left ventricle per beat, approximately 70 pum, multiplied by the heart rate. Then there's the systemic vascular resistance, which is the force opposing the movement of blood within the blood vessels. The radius of the small arteries in the arterioles is the principal factor determining SVR. Blood pressure must be adequate to maintain tissue perfusion during activity and rest. The maintenance of normal blood pressure and tissue perfusion requires the integration of both systemic factors and local peripheral vascular effects. So this is a slide more about the anatomy of it, and anatomy and physiology. So should just be a refresher for you. Again, this is to talk more about the background, the factors influencing blood pressure. This has a nice table for you to look at. The mechanisms that regulate blood pressure can affect either cardiac output or systemic vascular resistance, or both. So that's regulating it. Regulation of blood pressure is a complex process involving both short-term or long-term mechanisms. Short-term mechanisms, including the systemic nervous system and vascular endothelium, are active within a few seconds. Long-term mechanisms include renal and hormonal processes that regulate arterial resistance and blood volume. In a healthy person, these regulatory mechanisms function in response to the demands of the body. Each mechanism is more fully described in the following slides. So we'll talk more specifically about the sympathetic nervous system. This goes into the nervous system, which reacts within seconds after a drop in blood pressure, increases blood pressure primarily by activating this SNS, also known as the sympathetic nervous system. Increased SNS activity increases heart rate and cardiac contractility, produces widespread vasoconstriction in the peripheral arterioles, and promote the release of renin from the kidneys. The net effect of SNS activation is to increase blood pressure by increasing both cardiac output and SVR, also known as your systemic vascular resistance. Alright, so another factor influencing blood pressure is baroreceptors. So this is specialized nerve cells called baroreceptors. They're located in the carotid arteries and the arc of the aorta. They have important roles in the maintenance of BP, blood pressure stability during normal activities. They are sensitive to stretching, and when stimulated by an increase in blood pressure, sends inhibition impulses to the sympathetic vasomotor center. When a fall in BP is sensed by the baroreceptors, the SNS is activated. The result is constriction of the peripheral arteries, increased heart rate, and increased contractility of the heart. A couple more factors influencing blood pressure is vascular endothelium and renal system. So with the first one, vascular endothelium, this has to do with a single cell layer that lines the blood cells. It is essential for regulation and maintenance of vasodilating and vasoconstricting substances. The next we'll talk about is renal system. The kidneys contribute to blood pressure regulation by controlling sodium excretion and extracellular fluid. And the last factor would be the endocrine system. Stimulation of the SNS results in release of epinephrine along with a small fraction of norepinephrine by the adrenal medulla. Epinephrine increases the cardiac output by increasing the heart rate and myocardial contractility. I'm not going to go too much more into that, but just be aware of some of the factors that can influence the blood pressure. So these last slides were more of an anatomy refresher for all of you. So the next slide we'll go into is hypertension classification. So this is a beautiful graph for you all to be able to see the certain categories. So normal, elevated, stage 1, stage 2, and a hypertensive crisis. This was retrieved from the American Heart Association, and this has been updated. So this is the most current classification chart that they are utilizing currently. So when a patient comes in and their blood pressure is 110/80, that they're in the green, they're in the normal. Then elevated is when it's the systolic is between 120 and 129, and then the diastolic is less than 80. So you're in the yellow at that point, which is considered really pre-hypertension. Next is your stage 1. And then stage 2 is your systolic is 140 or higher. So if that were the case, then it would be stage 2. And as you can see here, this is or. So if your systolic is 145 but your diastolic is 80, this patient is still considered stage 2. And as you can see here with these first two with normal and elevated, that's and. So you need to see both of those. So if the patient is 130 over 96, they're actually going to fall into this category of stage 2. So this is a great graph to look at. Please save this. Please refer back to it. So here's a question. The nurse determines that the patient has stage 2 hypertension when the patient's average blood pressure is, and so it's actually all of these will be considered stage 2, because as we could see with that last slide here, 140 or higher, and I don't believe any of them are in a hypertensive crisis. So, oh, actually this last one, I'm sorry. So, 140, so all of these are stage 2, and actually that last one is considered a hypertensive crisis. So etiology of hypertension. So primary hypertension, also known as idiopathic, essential. This is when it is elevated without an identified cause, and it accounts for 90 to 95% of all cases. Although the exact cause of primary hypertension is unknown, there are several contributing factors. These include changes in the endothelium function related to either vasoconstricting or vasodilating agents, increased SNS activity, overproduction of sodium-retaining hormones, increased sodium intake, greater than ideal body weight, diabetes, tobacco use, and excessive alcohol intake. So those are all certain factors that could lead to primary hypertension. Then there is secondary hypertension. Secondary hypertension is elevated blood pressure with a specific cause that often can be identified and corrected. A little different than our primary, which it's not identified. The cause is not identified, but with secondary, it often is identified. An example of this would be pregnancy-induced hypertension. So this type of hypertension accounts for 5 to 10% of hypertension in adults. Secondary hypertension should be suspected in people who suddenly develop high blood pressure, especially if it is severe. Clinical findings that suggest secondary hypertension will relate to underlying cause. For an example, an abdominal bruit heard over the renal arteries may indicate renal disease. Treatment of secondary hypertension is aimed at removing or treating the underlying cause. Secondary hypertension is a contributing factor to a hypertensive crisis. So again, an example of this is pregnancy-induced hypertension. It is an identified cause that needs to be, it's already identified, but then it needs to, that underlining part of it needs to be treated and addressed. So this talks about the pathophysiology of primary hypertension. So this is blood pressure rises with an increase of cardiac output or SBR. Increased CO is sometimes found in a person with prehypertension. Later in the course of hypertension, the SVR rises and CO returns to normal. The hemodynamic hallmark of hypertension is persistent increased SVR. This persistent elevation in SVR may occur in various ways. Abnormalities of any of the mechanisms involved in the maintenance of normal blood pressure can result in the development of hypertension. Several factors relate to the development of primary hypertension or contribute to its consequences. So I am going to kind of move through these case studies as I am providing you with a separate case study to work on. So this one's just really for you to kind of go through and take a look at. But this last one, so it says, what risk factors for hypertension does CS have? So again, we've already kind of addressed this and we'll be talking about this a little bit more, but the risk factors for CS in this case study would be obesity, tobacco use, stress, gender, excess dietary sodium, and sedentary lifestyle. So I am going to pause here and I will return and we can discuss the risk factors for primary hypertension.